to our June SimCity rounds here at the Tamberdy Faculty of Medicine. So nice to see all these familiar, passionate faces joining us today. I hope more will wander in. It's with great pleasure that I get the opportunity to introduce a colleague of mine, Dr. Venkat Bhat. He was the first person to email me when I became faculty lead and asked for a meeting, and that stays with me. I'm like, this is a person who is heavily invested in simulation. He's an associate professor and a staff psychiatrist at St. Mike's Hospital Unity Health and Toronto Western, which is part of UHN. His research is at the intersection of disciplines enabled by academic appointments in medicine and engineering. He envisioned and developed the interventional psychiatry program at SMH at Unity Health as its director, a program which develops new treatments through interdisciplinary approaches. His focus is on invasive brain stimulation, not simulation, stimulation. And as the lead of AI and analytics at IBEST, IBEST stands for the Institute of Biomedical Engineering, Science and Technology, and the DIIG, the Digital Interventions and Intelligence Group, he has had a research emphasis on examining the development and implementation of AI algorithms in mental health. And his research integrates AI and digital technologies to enhance mental health care for various populations, including healthcare providers, indigenous communities, military personnel, first responders, and federal employees. So quite a broad net being cast there. He has more than 135 publications and 200 presentations. I think you're at 201 now, Venkat. His research program has attracted more than 8 million in funding as a PI and 1.5 million as a co-PI and 25 million as a co-investigator since joining our faculty in 2020. And he has received both national and international recognition for his work. So without further ado, Dr. Bhat, all yours.
Thank you, Petal, for the kind introduction. I'll get started here. So I just want to mention that I'm not a card-carrying education researcher. Although I was inspired by the simulation approach to do clinical studies, and which is what you'll see as I go through. A number of my close collaborations have been with people who do simulation in the education context. So the platforms which I've taken are from people who have worked in this domain for a while and, examined it really in the education context. So what you'll see is mostly about deploying development and deployment of digital suites in the clinical context, in the research context. And the second half of my talk will be about generative AI and the applications of generative AI, more in the clinical context, but we have one or two publications in the education context. So I just wanted to make things clear as to where I come from. That's my customary disclosure slide. All my work is peer-reviewed or investigator-initiated. I do not hold patents, no equity, and all the work we do is open source. We make everything we work. The codes are available, and so are the publications. So in terms of the objectives for the presentation today, I'll go over the work we've been doing on the prevention and treatment side of mental illness, the process for development of digital intervention suites. I'm sure a number of people here know quite a bit about this on the education front. I'll show how we've been doing this in the clinical side. And I'll go over a few specific projects we're involved in. We have publications as well. So if people want to get into more details, there are details available. I will be presenting more from the psychiatry side. I'm a psychiatrist as is Petal, but the topics are more broadly available. But most of what I'll be presenting will be from the psychiatry perspective. I know that this is not only a psychiatry crowd, it's a broader crowd. So just letting people know. So in terms of the group we have developed, what makes our group unique is we've brought together platforms, VR app-based and wearable platforms together as a digital suite. So we use VR to evoke stress, combined with psychoeducation. We use web-based platforms or mobile platforms for data capture. And we do subjective and objective data capture. Subjective data capture through mental health questionnaires, objective data capture through wearable devices such as the Aura or the Empatica. We're device agnostic. I've just mentioned a few common ones here, but we're more interested in the data and not in the particular device. So what makes us unique is we have deep expertise in the three domains. As Petal had mentioned before, I have one foot in engineering and the other foot in medicine. Half my team is engineering and half is medicine. And we really choose projects which bridge the two disciplines. It would not be possible for one discipline to do it just by themselves, but it would not be possible with the two disciplines working together. It's not possible for one discipline or one person to have more in-depth domain knowledge in one or two domains. So that's why people really need to work together. So our team, which I'll quickly show later, includes people across different universities and hospital research institutes with expertise in these different areas. What makes us unique, and you'll see that as I go through some of the work we've done, is we're able to take any real life scenario, create a virtual rendering of it, and see how people think, feel, and behave in this virtual setup, and then correlate that with the same kind of behavior in the real setup. So basically, we collect subjective and objective data in that virtual rendering of the real life setup, and then we have similar subjective and objective data collected in the real life setup. Some examples I'll show. We created a virtual ICU, a virtual ward, and then we had healthcare professionals go to the virtual ICU in the virtual ward, and we saw how they thought, they felt, they behaved in this scenario, and we were able to show that there were patterns which were actually similar to how they would behave, how they would feel, how they would react to stress in the real life context. So we have that work started in 2020 in the COVID context, and then it started off as UHN, St. Mike's, UFT, TMU, and then it broadened out to other partners. So the digital suite, which includes the combination of VR apps and wearables, we are able to take any real life scenario, as I said, and see how people react to stress. We have focused on developing signatures of stress response. So basically, features on the subjective and objective front when we put together, which actually predicts how people would experience stress when that same scenario is encountered in the real life setup. This idea is something which I actually took from the medical simulation field, working very closely with colleagues in medical education, and really deployed it in the clinical context, whether it's in healthcare. And as you'll see now, we're working with Canada Post. We're working with a few other organizations in terms of doing this kind of work. So when I said we develop a digital phenotype profile using data-driven methods, different methods, few of them are hypothesis-driven, more are actually data-driven. And we have come up with the individual signatures, which actually on the extremes correlate well. So when you look beyond 2 standard deviations, or even between 1 standard deviation and above, it doesn't do well in the median range. But when you look at the extremes, which is actually what we're more interested in, who's more likely to experience excessive stress, there's actually a good correlation. This is just a sense of some of the objective measures we collect. So we have people going through the scenario, but they're also hooked to different sensors which actually collect this information as they're going through this virtual reality simulation. And then many of these parameters are collected in the real life setup. So that's how we're able to correlate and predict with one predicting the other. We have published work on digital phenotyping of different components. What you see here was work done in the context of anxiety. We have also done work for depression, for stress, sleep, and we have a few other publications coming out as well, where we have taken together two modalities or more. It could be, either only the app and the wearable, or it could be all three, but we have come up with ways to actually phenotype specific objective parameters, fuse that with the subjective experience, and be able to categorize the stress outcomes. The development of this digital phenotype profile, these are, we have developed a basic algorithm which we have made publicly available, and we have actually then fine-tuned it for specific situations. So this is an example, where we looked at moral distress in this scenario, where this was a COVID scenario where the nursing professionals had to make difficult decisions, and you'll see the scenario later on, who gets the ventilator and who does not. This was at the peak of the pandemic, where still the decision making of who gets the ventilator was the staff within the ICU. It was later taken out of the ICU, but when this scenario was developed and deployed at that time, it was still the in ICU setup where the decisions were made. As I mentioned, we started off with a few groups, and then it's really expanded, going from one grant to the other. And we also have partners more internationally as well. I just want to recognize that all of what I'll show is because of people collaborating and working together across multiple sites. And we're a very collaborative network. People take the lead based on what really interests them and where they have deep domain expertise. And we work together as a network. So our funding sources include the work which I've mentioned before, and I'll mention as we move along, the traditional tri-council funding, but also sources of funding from organizations who are actually interested in terms of seeing our platform being deployed for stress, burnout, and other conditions within their organizations. So we are a multi-institutional group. We really leverage AI and analytics to decipher and understand the large data that is collected through these different platforms. I'll briefly show, and that's not the purpose of the talk today, but I'll briefly show how we've implemented all of this into the clinic as well. We've made our clinic digital, and I'll briefly show that. But my emphasis will really be on this digital platform, which we are deploying across different populations: healthcare providers, first responders, implementation studies, in Canada and international. So we're looking at barriers and facilitators to uptake of app-based, wearable-based interventions, internationally. Brazil being a good example, Mexico being another example. Then we have studies ongoing with the northern population, and I'll go through that briefly, and then the work with the Canada Post employees as well. So keep the digital suite, which I've mentioned before, in mind, the combination of VR apps and wearables, which is what we're deploying in all of these different populations. So this is the clinical program. I promise I won't get into the details of this, but I just want to show you how we've deployed digital data capture within our clinical program. So the clinical program I lead is the interventional psychiatry program at St. Mike's. We have a clinical arm and a research arm, and this is the way we have app, wearable, VR-based studies ongoing when people receive these treatments within the clinic. This has allowed us to do very unique trials in terms of people receiving ketamine, for example, and we're doing app and wearable-based data capture before, during, and after to see if we can look at sleep, activity, and other metrics, which may actually help us in terms of understanding treatment response, predicting early relapse, and details like that. So at the center is our clinical program, TMS, ketamine, ECT, and then we have a whole host of experimental treatments on the other side. And the clinical arm, we have an app which is downloaded, and we do measurement-based care, the routine scales which we want to collect as people receive these treatments. And then based on the funding we have and the specific trials we are doing, we may have the whole, VR app and wearable-based studies, or we may have only app and wearable-based studies. Having that digital platform has really allowed us to expand and get into research. I just want to mention how we ended up in this. So, when I came on faculty January 2020, we had funding to do all of this, the pharmacology and brain stimulation. The digital was really not something we were thinking of. Then March 2020, we had COVID. We couldn't do anything. We were basically sitting on grants and not being able to do anything. So we quickly pivoted towards the digital interventions, because people wanted everything remote, and there was an emphasis on that, and that took a life of its own. And what became an afterthought has become our preoccupation now. Like, more than 2/3 of my program now is on the digital side and the AI side, and I see myself as doing more and more of that and less of the other things. So that's a little bit of the background. In terms of the work, I'll go through specific projects and some of the results, and then I'll spend the second half of the talk speaking about generative AI in particular, and the opportunities there, but also the challenges which generative AI represents. So before I go into the generative AI side, I'll go over the different populations where we have deployed this platform and the kind of data we have been able to obtain, and what we're planning to do, like what we've been funded to do in this space over the next 3 to 5 years. So I've mentioned that we've used a combination of virtual reality with apps and wearables. We basically take real life circumstances. We work with the end users, whether it's military personnel, Canada Post employees, Northern personnel, or healthcare providers. We see where the pain points are, often why people have left these organizations, and we work with them to generate scripts of what led them to leave the organization or what led them to have difficulty in the organization. And we beta test it, and they tell us how realistic the scenario is, and then we deploy it to people in the organization with the hope that we can actually help people to see how they react to these stressful situations, and are there other ways to actually react to them. So our work was grounded in looking at what other groups have been doing, particularly in the stress realm. The work is published. We've done systematic reviews and also meta-analysis looking at virtual reality as a way to understand stress, anxiety, symptoms of depression. Can we use VR as a safe and way to provide controlled exposure to stresses? And although the outcomes are not very, very clear, in terms of the efficacy, there's certainly a change in terms of what you're trying to change, but the standard deviation is also large, which basically what I'm saying is that there's heterogeneity, which means that we need to more carefully screen and decide which subsets, whether it's anxiety, stress, or depression, would actually benefit more from these specific interventions. So I'll mention the work we have done in the COVID context, really very closely with healthcare providers. A lot of credit to the Ontario Tech team, Adam Dubrowski and Bill Caprolis. We have worked very closely over the years to develop the platforms. Adam is a medical education simulation researcher, whom many of you listening today would know. A lot of this was started off with Adam, Bill, myself discussing what can we take from the education context and actually deploy it in terms of helping people understand the way in which they would respond to stress. So this is a quick run on how we develop the scenario. I'm not going to take time going through each one of them, but I think I've mentioned the steps in terms of how we work with the end users. We develop the scripts, and then we beta test the scripts with the end users in mind. In this case, it was nursing professionals. This was an ICU scenario, where the nursing professionals, the team had to make difficult decisions. And then we use subjective questionnaires delivered right during the simulation, but also objective data collected. And then we have people in the real ICU where we actually collect data. So I'll just take a moment here to show you a clip of the video, and then I'll come back to my presentation after again. So let me just. So this is the scenario. This was our initial scenario. We have gotten a lot better after. So this was with Adam and Bill's team at Ontario Tech and our team at TMU working together. So basically, this is a virtual ICU where the team has to make a decision on who gets the ventilator and who does not. We had one person who, there are two settings, and the person who should have gotten the ventilator does not. And there are a lot of elements of moral distress and ambiguity in terms of making the decision. So what you see initially is people getting into the scenario and feeling comfortable to use the VR equipment, and then they're given directions as to what would happen next. They feel comfortable with the VR setup, and then the scenario starts. So this is a setup where we have the administrative coordinator and the nurse deciding, as to what the next steps are in this particular scenario. I'm not going to go through the scenario. I just wanted to get a feel for how we have developed it. And this is in 2D, and I've taken out all the sounds, and it sounds like a real ICU with everything in the background and decisions being made. So people stop at different time points, as you see here, where we collect the subjective data. So this was loaded really on the moral distress and ambiguity side. That was a grand priority at that point in time. We're speaking about 2020 here at the height of the pandemic. And then the person is able to take the role of either the physician or the nurse or the ambulatory staff, and then there's a discussion before, and then they go in. And this is speaking with the family of the patient and having to make the decision. So it's a tough discussion, and the outcome is not really good. And basically, the family walks out of the room, and there's a debrief at the end where the team, like would happen in real life, there's a virtual huddle, if I can put it that way. And what we've also done, so I'll in the interest of time, I'll move forward, but I just wanted to give you a feel. So imagine that this is happening, and you have different sensors collecting different objective data as you're going through this. So we're getting all the subjective data of their stress experience, and also collecting different objective data, which includes EEG, ECG, heart rate, blood oxygenation, skin conductance, many other parameters. And then in the real ICU and the real ward, we're able to collect many of these parameters, not all, but many of these parameters. In this particular setup, we also had an educational intervention, which we deployed during the midway during the scenario. And we also had people come back to see whether their experience of stress was actually different, and what was actually retained by virtue of them having had this educational scenario. So basically, it's 3 runs here. So you've seen the initial run where they experience the situation. Then there's an intervention of an educational component. Then they return back to the scenario again later to see if their experience of stress is any different, and we have subjective and objective data there. So I'll go back to my presentation slides. It's a lot more realistic with the headgear and all of that on. But I thought I should give you a quick visual feel of what the scenario looks like and what we've been able to develop. So this is we have published all of our work, each one of them. So we started off with phase 1, which was the virtual ICU. And then we were funded to do a larger trial where we were asked to develop the virtual ward. And I will go through some of the results we have at the virtual ICU and the virtual ward, and how we have then positioned it for similar scenarios across other organizational contexts. So when I say organizational contexts, I mean, what a person in an organization like Canada Post would experience on a day-to-day basis, what a person living up north would experience in remote communities, and how these platforms could actually be helpful. In the middle of all of this, the Department of Defense got really interested in our work, and they said, could you generate pre-deployment scenarios? So could you have military personnel exposed to scenarios they would be deployed to before they're deployed, so that we can do the same approach, the signatures of stress response, with the view of identifying who's more likely to experience excessive stress, and maybe the ones who experience excessive stress are more likely to experience PTSD. So it's more on the prevention side. So that's a 5-year project we now have, and we are actively working on taking the same platform or paradigm which started off with the pandemic and the virtual ICU and the virtual ward, now to different organizations, and now also to deployment within the Canadian military. So this was the initial work, and I've shown you the first video in the first sim setting scenario which we did, where nurses have to choose which patient to save in the crisis environment. And we collected different modalities of data. So it was this is the second phase of the study, where we did it in the ward. Similar idea, we had a difficult situation which we represented in the immersive setup, where the outcome was not really good. It was a code stroke environment, where there's scarcity of resources, and the nursing professional had to make a decision on who gets the equipment to run the code stroke. So there are a number of ambiguities involved, which, during the pandemic was, something which people had to face, not after, but we also wanted to look at how people make decisions in the context of scarce environment, scarce resources. So this was the setup where we have the app and the wearable. For this study, we used the Aura, which is ring which you wear around the finger, and it actually collects activity, sleep, and other physiological data. And then we have them on the GreenSpace platform, which allows them to give subjective measures of their stress. So in real time, in the real ICU, when they're in similar situations to what they experience in the simulated environments, we're able to look at their stress experience. This is just a bunch of our publications, but as I mentioned before, our publications are all broadly available. So we had 100 people in this study, and the work is just in the process of being accepted. Our phase 1 results are all published. Phase 2, we completed it last year, and we have a series of publications coming out, on some on the engineering side about how we have developed the methods, a lot more on the clinical side in terms of how we have used the platform to help with understanding the stress experience. So this is a different rendering of the same data we are collecting at different time points. I go back to we are followed by the app and the wearable in simple terms, but this is giving you more details on the specific data being collected. I'm not going to go through the scenarios. We have 10 scenarios like the one I showed you before at the outset. So in this case, as I said, this is more of a code stroke scenario, and the difficult decisions have to be made and the outcomes are not good. And the point is not about the scenario itself, but it's about how a given individual actually navigates and makes decisions through the scenario. We have different decision points and decision trees where the experience is very different for two different people based upon the choices they select as they go through the decision tree. So this was the some of the results. So we looked at subjective units of distress. You see SUDS here, the MIOS, which is the moral injury outcome scale, and the heart rate variability. What we're able to show is that there was a change in terms of features before and after. And most importantly, when we bring not anything in particular, but when we use a number of these parameters together, we're able to come with signatures which are specific to the individual's experience. Um, um, Another critical thing which we learned, our phase one engagement was pretty low. So we had dropouts of about 30% or 40%, which um, people who have worked within the digital domain with apps and wearables, in theory, you can collect great data. But in practice, you collect poor data. And there's a lot of missingness. People don't complete the scales, people don't charge their wearables, people don't have the wearables on them. So keeping people engaged and what strategies to actually engage them, this is something we worked on from phase one, where we had about 60-70% compliance, to phase two, where we had almost 95%, 97% compliance. And I won't get into all the details of that, but we did many different things. Like every 2 days, a coordinator from our team would follow up if there's data not coming in. That's one example. We had engagement sessions on Zoom. We customized the choice of scales and also wearables based on what people wanted. Um, and the other thing we did was also based upon the completion, there was also reimbursement. There was a base reimbursement for everyone for participating, but also people who, completed regularly were also able to get a higher reimbursement. So we had to bring in many of these measures so that we could collect the data which would be meaningful. And we were able to get really valuable large data, and this is an example of how we put together some of the wearable data, the sleep and activity and readiness features, to come up with um, um, experiences or signatures, as we call them, which were specific to particular individuals. So I won't get into all the details here, but basically what we've done is we have deployed and developed this for other populations, Canada Post being an example. I've already given you the context there. This is work we're particularly excited about. 2 weeks ago, I was in this remote community of Nain here in Labrador. So the pain point here is that uh, we have 6 family physicians basically providing care for this whole territory. And along the eastern seaboard, we have 12 communities which are largely indigenous, and the family physician basically flies from these community uh, to these communities from the main hospital, which is in Goose Bay, every 2 months. And there's no sense of what is happening in between. And most of the care there is provided by allied healthcare professionals and occasionally nursing professionals. So we're using virtual reality, working with the indigenous communities there they are actually leading this. I'm the co-lead of the project in the local language, and scenarios being developed in the local context. So you can think of common presentations of anxiety, depression, substance use, intergenerational trauma presented. And there's a physician component, in this case, the frontline provider component. There's also a patient component, a different take on the same, but what the patient is able to experience. And then we have a subset on wearables so that the physician thousands of kilometers away has direct access to this kind of data. So this is a lot of work with the indigenous community, and all the data being stored locally, and a number of issues around that. So this is a 5-year project, and we're 2 years into it. I want to give 2 examples of how we have integrated wearables into our clinical work. So we have an ongoing trial with psilocybin for PTSD, where we are doing app and wearable-based data capture, particularly wearable-based data capture. So this goes back to how we have integrated some of these three platforms, either individually or together within the clinical setup. This is another study we're doing where we're looking at Dayvigo, approved in 2019 for sleep. We're doing a study looking at sleep in the context of depression and using wearables and for continuous sleep and activity data capture. So basically benchmarking it against features you would get through a polysomnography-based sleep lab study, not with that kind of resolution, but you cannot have someone going to a sleep lab every night. So you get proxy measures of this. So you look at the latency of sleep, how long it takes the person to fall asleep, the different stages, REM, non-REM, how they cycle between the stages, early morning awakening. You get this information pretty clearly. The other is the activity data. This is another trial which is almost getting completed. A lot of our studies really come about because, I'm speaking with people and I see that me or the larger group of people within our network, they see the possibility of being able to deploy one or more of these platforms. So I'll uh, mention how this study came across. So this is really looking at using personal data or digital data to see if you can enhance physical activity among university students. So there's a program at U of T which has been around for a decade called Move You, Happy You, which is basically a personalized physical activity program. And the difficulty is that the trainer does not know if the student is actually doing any physical activity, and it's not possible to tailor treatments if you don't know what interventions if you don't know what kind of activity the person is doing. So we said this an easy solution here. We can have them on wearables, and we can actually know whether they're doing aerobic or strength, what's the nature, how many minutes, and actually we can give access to all of this data. And that's the other critical piece. With all the studies I've shown, people actually have access to their own data, app and wearables, whether it's the nursing, Canada Post, Northern, or students here, they have access to their own data. And you can see the correlation. The days where you're more physically active, your sleep is better, your mood is better, your concentration is better. We're trying to see whether people having access to their own data and the end user, whether it's the physician or in this case the physical activity trainer, can actually customize the interventions and lead to better outcomes. We have been looking at different modalities of data collection. I'm now moving over to the generative AI phase, and I'll skip a few slides in the interest of time. I want to keep at least 10 minutes for questions, so I'll try to finish in the next 10 minutes. But it's basically going over a few publications we have in the last year or two. We have a number of new projects. We're focusing quite extensively in the generative AI realm. So why I don't need to mention the benefits of AI to this crowd: personalized adaptive learning platforms, automated performance tracking. We are particularly focused around conversational agents and virtual assistants. It is very feasible to do it these days with in a very conversational format. It allows for realistic clinical scenarios and patient interactions, and could also lead to enhanced teamwork and communication skills. Again, I don't need to go through the benefits with this crowd. With AI-driven virtual patients and clinical scenarios, you can also get real-time performance analysis and also do adaptive scenarios. I mentioned about the work where we have these decision trees where it branches off, making it more adaptive, and it allows for immersive and personalized training. We've been doing quite a bit of work on synthetic data. With generative AI, the benefit is that you can actually create a number of these scenarios where we go from the script to the scenario pretty quickly. It would usually take us 3 months and a lot more funding to go from a script generated from the end user to a scenario. Whereas now, this process is really accelerated. And what we're trying to do is to see what this means in terms of the end product, and is it really leading to scenarios which are better or of the same quality as compared to what we were able to do in previously without using generative AI. So we have published this thought piece on opportunities and barriers of generative AI in training psychiatrists. I'll be going through a few of these um, um, sections in the next few slides, but the paper is published. There's another coming out, which will be out in the next few weeks. So generative AI, which captured people's imagination in November 2022 when ChatGPT was released, it's being increasingly used in education and healthcare. And psychiatry training, as everyone knows, as our other modalities of training, involve complex competencies. And in this particular paper, we looked at the opportunities and the challenges. There are a number of these which are available, and each of them, this changes by the day. And what's even more interesting these days is going from a generative AI lens, the large language model lens, towards large, towards the agentic AI space. So the difference between agentic AI and generative AI is really the degree of autonomy in terms of decision making, and being able to go from point A to point B with minimal supervision. That's in the works. We don't have many agents at this point, but it is an area of intense research in terms of taking specific tasks and being able to have a degree of autonomy to it. So think of it as you can use generative AI to have a conversation on the Copilot or Grok or Gemini or GPT, but you can also embed decision making into it. So I'll make it even more concrete. So let's say you want to book a travel itinerary. You can give some details and it can come back with most of the specifics you would need. The agent can come back with most of the specifics you need to be able to do that booking. So it goes from just information to being able to take action on it. The one difficulty with the people are increasingly using these platforms for self-diagnosis. So this is a paper which has been published. This is with colleagues at the University of Waterloo. So basically what we did with this is to see if patients were to use this for self-diagnosis. And if you actually look at why people are using GPT, from the medical side, the number one or the number one or two most common reason is actually mental health. People are asking questions about what symptoms they have, what conditions they may have. And what's interesting is that if you give it a structured question like you do in USMLE, it'll do pretty well. A lot of these things, it's been very well shown that they do better than the resident, and in some circumstances as good as the average physician. But if you take this in an unstructured way and have people actually discussing it and having back and forth on it and coming to a decision. So as you increase complexity into this, which is what you see in real life, the response actually goes a lot down. If you give it very clear, structured answers, questions, and say which of the four is the right, and you actually name the four, it'll do pretty well, and it'll do as well as the resident. But you don't give all of those choices, and it's an ambiguous kind of setup, then it actually makes quite a few errors. So I think this is the status today, and it's continuously improving. But I think this is something for us to keep in mind. I won't go through all of the details of it. This is in the manuscript which I showed before. So the opportunities with generative AI in terms of enhancing diagnostic training, supporting treatment planning, improving communication skills, and potentially bridging knowledge gaps. Again, my area of work is not in the education space. I'm more in the clinical space of looking at how these platforms, whether it's generative AI or the other digital platforms, can be used in the clinic to enhance patient care. But this was a piece we wrote together to see that there's quite a bit of potential to use the same in the education space as well. Barriers and challenges, there are a number of ethical and bias concerns. AI may reinforce biases from training data. There's risk of over reliance. Trainees may depend a lot on AI instead of developing clinical intuition. There are a number of issues around using AI in psychiatric training as well, in terms of confidentiality, and questions and concerns around what is the appropriate use. And when I speak with faculty members, and actually it's such a rapidly evolving field that um, large institutions like U of T don't exactly know how to come up with a policy around this, because you come up with a policy and it's already out of date as soon as you come up with a policy. So um, the I don't think we can say people should not be using generative AI, but the point is more to see how we can use it so that what people need to know is not um, uh, compromised. So we want people to know and then use these platforms, rather than use these platforms and not be able to actually know what they're supposed to know. In the interest of time, I'm actually going to stop here, but our publications and materials are actually available. And if people have questions, they can actually feel free to reach out to me.
Thanks so much, Venkat. Great presentation. We had a few people drop off for different reasons, but this is being recorded, will be put on our YouTube channel for those who usually catch it after. And then also Simulation Canada also has our YouTube SimCity rounds on their channels. So fear not. There are many people that will be able to hear about your wonderful work. I do have some questions to get the ball rolling. You were talking about, I was especially caught up in that video you showed with the ICU decision making. What are some of the interventions that arose, or the changes that were implemented that from the stress of the moral distress and the decision making around that time? Can you share a little bit more about how that
Yeah,
work grew?
yeah. So when we started off, it was um, what what's called a proof of concept clinical trial. We were given a technology readiness level scale, um, and we were told, bring together the app, the wearable, and the VR context, and show that you can actually take a real life scenario, render it in virtual settings, um, capture people's stress experience, which actually reflects what people experience in real life. That was the first phase of the study, and we brought
Mhm.
the team together across disciplines, and we showed that it was actually possible. The next phase of the work was, how do we iterate on it in ways which are actually meaningful for the individual in terms of uh, the 4P medicine approach: preventive, predictive, participative, and personalized. So this is where people have access at the end um, to the ways in which they've actually um, handled the specific stressful scenarios. They also get summaries of their sleep, activity, and other details during the 3 months of the trial, whether they're in the virtual ICU or the virtual ward, or now in Canada Post or the other organizations. And then that information allows people to reflect and see if they could have handled the scenarios differently. So the outcomes of that we are actually working on to actually demonstrate that there's immediate learning, there's routine learning, which actually lasts upon completion of these digital platforms. And actually, upon completion of the trial, people continue to use the apps and wearables in a positive way. The other thing we have also built in is interventions. I showed you how we have the VR setup, and then we have an education module around what do we know around this circumstance, what do we know about moral distress, and in the virtual setup, does it lead to people handling the situations differently? And their objective and subjective experience of stress, is it any different? And then does it actually translate to them being in the real world? So these are the iterations, like the phase one, phase two, phase three. Um, Taking the same medical education paradigm you have, where you're looking at people's skills and seeing, is there anything you can do to enhance their skills, like the resident operating on the mannequin before they operate on the actual, in the OR. What are the skills? What interventions can we give? We're taking that more to real life, where other subset who should not be deployed, like with the military, they should not be deployed because they need to get more interventions. Because once people develop PTSD and other conditions, it's a bit too late. So I've just given you a couple of ways in which we are actually using this in the real life settings.
Thank you so much. And that's really exciting. As a geriatric psychiatrist, I was particularly interested in the wearables at night, to, replicate the sleep study aspect and impact of sleeping agents like lamborexant, because elderly people, that's when they tend to fall and break their hips and get head injuries. So, I think it's a whole new world, an exciting opportunity for us to really support our patients better and understand some of the risks that they are exposed to, especially with the medications we use. Jabeen, did you have any questions?
No, just a comment. Like, I think Venkat's presentation given me a lot to think about. That how, if used appropriately, technology can help. Although, like, we always have this fear that if we get into it, it will be a never-ending journey. But I think with Venkat's presentation, it gave us the hope that yes, it might be a little bit a learning curve, but things are possible and people are still doing it. So I think what I learned from his presentation, that rather than starting from scratch, find out people who have done it before, learn from them and build over it rather than building from the scratch. And it comes to the same point. Don't remain in your own container or silo. Just go out of it, make it available for others and learn from others. And then probably you can deploy or adapt it better to your setting. So thank you so much, Venkat.
Yeah. Thanks, Jabin. And I actually learned from the education simulation folks. I took this from the simulation context. It was Adam Dubrowski, Bill, and myself discussing and bringing this to life. So what you said is, we have to learn from the clinical to the education, to and the research contexts, and we don't have to reinvent the wheel. Two things I would mention is, we really have to co-develop these things. It's not one person, sitting. And as I've mentioned before, all of our scenarios and what digital platforms people want to see, it's the end users who actually tell us. And that's really critical for the utility, but also to be able to deploy this. The second thing is, which is actually tied to the co-development, is a lot of these things, it is good if people are able to use them, but the practical reality is it's very difficult. If people wear the Aura every night or another wearable every night, and they're on lemborexant, you can know beautifully what their sleep is like. But the difficulty of getting them to wear, and that's where the co-design aspect is actually critical. I'll just end with, I think we need to be careful, because a lot of what I've shown may actually not be useful. So we need research to see what is useful, and think of the EMR, like we thought it'll save all of us work, and here we are with EMR contributing to physician burnout and all the additional workload and all of that. So I think a lot of research needs to be done, and that's why I feel we should go with the optimism that this is not going to work. So
Yeah.
and then actually you're surprised if it works, not the other way around, that this will work.
Well, thank you so much, Venkat. I think we have 1 minute to the hour, and so we'll wrap up here. This is the end of our SimCity rounds before the summer, so we'll take a hiatus for July and August, and then we'll be back in September. We will be emailing you with flyers for our September presenter. And I appreciate all of your time and willingness to join us today. Thanks so much again, Venkat. Take care.
Thank you. Take care.
Thanks, Gretel.
Bye.
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 Bye.